Hello, everyone. My name is Deborah DeBruin, and I direct the Center for Bioethics here at the University of Minnesota, and I want to welcome you all to Ethics Grand Rounds. We have what promises to be a really important and very interesting discussion today about trust among ethnically diverse patient populations. Before I introduce our speakers, though, I would like to work through some housekeeping items, if you will. Next slide, please. So if you have any questions for the speakers, please use the Q&A function that you can find at the bottom of your screen to type in those questions. You can type in follow-up questions for the speakers that way as well. Please also use the Q&A function if you have any technical difficulties, and Center for Bioethics staff will be able to follow up with you privately that way. Please do not use the raise your hand function. We're not able to manage that functionality during today's webinar. The webinar is being recorded. You will be able to access the recording of the event within a day or two of the event in the at the center's YouTube channel, and you can see the web link on the slides. It will also be sent to you in a post-event follow-up email. We have enabled captioning for this webinar to improve accessibility. If you'd like to view captions, please go to the bottom of your screen, click on captions, and then click on show captions, and that should take care of it for you. Again, if you have any difficulties, please use the Q&A function to contact Center for Bioethics staff, and they will help you. We would ask if you would be so kind that you complete an evaluation after today's event. We take the feedback that we get from our participants very seriously as we plan follow-up events, and it's very useful information for speakers. There are 3 ways to access the evaluation. When you close out your Zoom window at the end of the event, it will pop up in your browser in case you have time and are interested in filling it out right away. It is also linked in the presentation details document, which Center for Bioethics staff have made available in the chat. That document has a ton of really useful information about today's talk. You'll also receive a link to the evaluation in an event, in an email after the event with a link to complete it. We just try to make it available to you that many ways so that it's convenient for you to fill it out. So we do really appreciate your feedback. There are a number of ways you can get credit for attending today's event. If you'd like to request a certificate of attendance for CEUs, please complete the form linked in the presentation details document. If you are a University of Minnesota health profession student and you would like to get interprofessional education credit for attending today's seminar, please complete the reflection form that is linked in the presentation details document, and then we will work with you to make sure that you can secure credit. Biomedical engineering students, if you would like to receive credit for attending this webinar, please follow the instructions on the slide there. Submit the event name and the date in the Bioethics Grand Rounds attendance quiz found in the assignment tab on your course's Canvas page. For everyone, our understanding is that you must attend 75% of this webinar in order to secure credit. Next slide, please. At this point, I'd really like to thank our co-sponsors. All of our Ethics Grand Rounds events are brought to you in partnership with other programs here at the university that really helps us to provide you with the programming that we are able to provide. So today I would really like to thank the Center for Anti-Racism Research for Health Equity from the School of Public Health, the Center for Race, Indigeneity, Disability, Gender, and Sexuality Studies from the College of Liberal Arts, the College of Pharmacy, the Medical School, the Program in Health Disparities Research from the Medical School, the School of Dentistry, the School of Nursing, the School of Public Health, the Department of Pediatrics, and the Community University Healthcare Center. Thanks to all of those programs for their partnership. Now, without further ado, I would like to introduce to you today's speaker. I like to think of these folks sort of as the home team, as I was saying to them. They are colleagues and partners that we work with all the time here at the university. So I'll start by introducing Jennifer Needle, who is an associate professor in the Center for Bioethics and the Department of Pediatrics here at the U. She serves as the co-chair of the University of Minnesota Medical Center Ethics Committee and co-lead for the Clinical Ethics Consultation Service for mHealth Fairview System Hospitals. Next will be Shannon Pergament, who is a founding member of the Somali, Latino, and Hmong Partnership for Health and Wellness, which we call SoLaHmo, a community-driven research program at Community University Healthcare Center, which is a University of Minnesota affiliated community healthcare center in Minneapolis. She has over 25 years of experience working in collaboration with ethnically diverse communities to maximize community health and manage community academic research partnerships. And last but not least, we have Sey Lee, who is a Hmong community researcher with the Somali, Latino, and Hmong Partnership for Health and Wellness, or SoLaHmo. She has experience in clinical research coordination and case management for populations that are uninsured or underinsured, of limited English proficiency, undocumented, and unhoused. We have a lot of talent and expertise and wisdom here on the panel today, and I am delighted that they are joining us, and I want to say welcome and thanks to all of them. And at this point, Jen, I will turn it over to you.
Thank you, Deb. And just to be clear, everyone can see my slides now, correct?
Yes, they are perfect.
Wonderful. And none of us have any disclosures or conflicts of interest to disclose. Thank you so much for having us. We're really thrilled to be here today to talk to you both about our work as a community academic partnership team, as well as public health and health equity researchers who are looking specifically at experiences among Somali, Hmong, and Latin American families of children who have serious illness. And so we will talk some about our work, but the key findings of our work that led us to develop this talk were that major themes of trust exist in healthcare, and we wanted to address on a global level what we know about trust as far as barriers and facilitators among the general public as well as among communities of color. We will use some time today to demonstrate how community-based participatory action research really is the model for how we should be looking at these type of questions, and share some of our results with you, as well as provide some recommendations for ways in which individual providers and systems may work to improve trust among parents of children with serious illness and patients in general. So when we talk about trust, there's numerous definitions, but quite honestly, this definition is one that I rely on in the sense that it talks about trust being assured reliance on someone or something. And when we're talking about trust in the healthcare community, specifically among ethnically diverse communities, the assured reliance is lacking. And so there is a issue every time people interact with the healthcare system where they bring previous experiences that have not demonstrated reliance on someone's character or ability. And I think that it's really critical to understand that trust is a living process. So you can't watch the news now without seeing myriad of headlines about people saying how they've lost trust in the health system. And as I show these, I want you to recognize that the majority of literature, quite honestly, comes from issues of people talking about institutional trust and trust in the healthcare system as a whole. And what we'd like to focus on today is something more relational, talking about interpersonal trust between patients, families, and providers. We recognize that providers work within a system and that systemic mistrust may very well influence interpersonal trust. but we'd like to spend our focus today recognizing that there's a pretty significant mistrust both among healthcare providers and the public in the functioning of the US healthcare system, which has gotten significantly worse since COVID. And while we recognize that there is significant work to be done on a system level to improve elements of trust among patients, we are going to focus a bit more on the more interpersonal aspects. So nearly every study, whether it be a focus group, a questionnaire, interviews, or large-scale research studies, show what characteristics of providers engender trust by their patients. Very clearly, communication, quality, quantity, and tone of communication is by far the most important thing that engenders trust. I think it's really critical to emphasize here that of communication on a daily basis, less than 10% of it is actually verbal. So when we talk about communication between providers and patients, we have to recognize that tone, body language, and mannerisms also clearly impact the way patients perceive communication from providers. We also know that patients want to feel cared for, that they want to know that their provider isn't seeing them in some transactional way, but rather sees them as a human being who's having an illness experience and needs their care. We also have to acknowledge that the vast majority of literature on trust in healthcare comes when it's examining the patient or family trust of the provider. But what our work showed, and we will present to you soon, is that patients cannot trust clinicians if clinicians do not demonstrate trust in their patients. And hence the title of our talk, Trust Takes Two. So what do we know about how providers represent or demonstrate trust in their patients? There's very little literature on it, but we can infer from some literature that providers demonstrate mistrust by lack of quality listening to patients. So most everyone can probably reflect on experiences they've had where patients present. This is in an outpatient setting, but I think it probably exists in nearly every setting. And when providers met with patients, only about a third of the time did they ask them what the patient wanted to accomplish in the encounter. And when the patient started talking, providers interrupted them very quickly. And this is clear demonstration that the providers are viewing this interaction as a transaction and not one where they are wanting to hear and understand what their patient is saying to them, and thus they don't demonstrate trust in their patient's information. Even more egregious, we can talk about evidence that shows providers don't trust patients based on the way we refer to patients in the medical record. Recognizing that the electronic medical record is a living document and that there is plenty of cutting, pasting, and forwarding notes from one day to the next, it's been demonstrated that negative connotations about patients in the medical record persist from note to note among different authors more than 70% of the time. And when we look at these types of words that providers use to describe patients, which really represents a lack of trust in the patient, we can even talk more about how bias interferes and impairs trust. That a recent study showed that Black patients were 2.5 times more likely to have words such as these represented in their medical record. So we know what patients want from providers to show trust. We also know that providers do not do an adequate job of showing their patients that we trust them. And when we talk about patients that have high medical needs, the questions of trust are ones that become really critical for us to address. Patients that have high medical needs, consistent interaction with the healthcare system, need to feel as if they're trusted and are able to trust. So our work focused specifically on parents of children with serious illness. I would like to acknowledge that serious illness is different than chronic illness. A significant portion of children in the United States today are living with chronic illness, which includes things like asthma, ADHD, or obesity. But serious illness among children is one that is present and increases their risk of mortality, or on a daily basis, it impairs their ability to function. So among children with serious illness, we're categorizing that as children with profound neurologic disorders, cancer, genetic disorders, technology dependence. And if we look at this chart in the bottom corner, these are the top 5 referral diagnoses to palliative care. It is believed that every child who is diagnosed with serious illness qualifies for referral to pediatric palliative care. And thus we can use the palliative care literature to demonstrate in some ways the demographics of children that exist with serious illness. When we talk about illness, trust, and the healthcare experience, we have to identify the role of intersectionality in patients' experiences within the hospital setting. This has been a particular area of interest in our work, recognizing that there are significant barriers and facilitators to trust within the communities that we worked with that have to do with the degree of their intersectionality. People's immigration status, people's language fluency, their financial situation, whether they're recent immigrants to this country, their understanding of the healthcare system, are all factors that are influential in how patients experience trust, communication, and their interaction with the healthcare system. And when we talk about children with serious illness, we can add another bubble beyond the one of physical health that's seen in this picture to one that talks about need for chronic interaction with the healthcare system, which is the experience of many of these parents of children with serious illness. One of my colleagues, Brian Sisk, created this very nice model about how we can think about trust and the role of intersectionality in trust. And I think this is really critical to understanding what we can do to both impair and improve trust between our patients. And the summary of this slide really goes to show that when patients are originally diagnosed or initially diagnosed with serious illness, parents are in a position where they have to trust the medical team. They have to trust that the doctors and nurses and care providers have competence and capacity to manage their child's clinical needs. And part of the reason that this trust is really based on competence is because there is a profound power differential that exists among all parents of serious illness when their children are first diagnosed. Oftentimes, these children have complex multi-system disease. They have numerous subspecialty providers helping care for them, many times who have differing opinions about how to manage the child. And they may have already had experiences with the medical system that leads them to come into it with a concern for both the capacity, but the ability for medical teams to have their best interest at heart. So I think we have to be very aware that at the time of diagnosis, this power differential exists at its greatest, and that while families are depending on us to exhibit medical competency, this is also the time at which they recognize whether or not there is going to be trust between them and the care team. I will note, as C presents our results from our work, that a significant number of our patients were in our study were from the neonatal intensive care unit. So these are parents of children with serious illness who were very recently diagnosed and very recently aware of the serious nature of their child's illness. And many of them existed in this competence-based trust phase, but it was very clear from their comments that very early on, despite trusting the competence of the providers, occurrences had happened that led them to have mistrust. And why this matters is if we move over to the time of, on the right side of time of crisis, With the medical complexity many of these children have, there is very likely to be a medical crisis in their future. And at the time of crisis, it's even more critical that patients and families are able to trust their providers. And at this point, if providers have established enough trust with patients and families start to make decisions and base their experiences on things like honesty, how caring the providers have shown themselves, how true they've been to their word. And so developing trust with patients begins at the time of diagnosis and continues throughout the continuum. So when we're talking about serious illness, how does intersectionality come into play, and why do we need to think about it? Oftentimes in cases of children with serious illness, there are complex decisions to be made, whether to proceed with surgeries, whether to transition to a comfort-only plan of care. These heavy decisions require capable communication and an awareness of factors that really matter to the family and how they make decisions. We know that different communities have different experiences with how they perceive decision-making. Some families want a lot of information and to be involved in shared decision-making from the beginning, and others feel that they rely on the doctor's recommendation. There's a significant importance to our recognition of the role of religion and spirituality in how families make decisions, and our querying of how they want that to be included in the process of communication is really important. We also have to recognize that our white Western conception of a good death or lack of suffering is contextual to our own experience, and that many of our patients view these experiences in many different ways. And having a curious attitude and understanding how they perceive the role of illness in their experience is really critical to engendering trust in how we communicate. So before I turn it over to Shannon, I want to give you a brief introduction into our work that really led to these future projects that we're talking about and some of the recommendations that we'll share with you at the end. In January of 2020, we were fortunate enough to be funded to perform a study as a community academic partnership team. So our team has changed over the last 3 years, but was constituted by academic partner, myself as an academic partner, and the SoLaHmo Partnership for Health and Wellness, including community researchers from the Latin American, Hmong, and Somali communities. And our goal was to explore the serious illness experience of parents as well as healthcare workers in the community to understand the need for interventions to provide better quality serious illness care. So we conducted interviews and focus groups with 3 key stakeholders, as well as including community and religious leaders from these 3 communities, pediatric physicians and nurses, and then groups of parents from these 3 communities, as well as developing a community advisory board with leaders in the areas of healthcare, pediatrics, and palliative care. And I would like to turn it over to Shannon to share with you what approach we use to conduct this research, and comment that it's really critical when we talk about our results to recognize that it is highly unlikely we would have had many of the results or found many of the results and been able to interpret the data the way we had we done this project in any other format. And so we, as a team, want to present to you the value of doing community-based participatory action research.
Thank you, Jen. Thank you for laying the kind of overview and background of why we did this research. And I'm now going to share with you kind of the approach that we took and the CBPR approach that we took. I do want to just add from that last slide, or to that last slide, that our community advisory board was also made up of some of the parents that we interviewed and some of the community leaders that we interviewed. And so we were able to engage them in some of the analysis and interpretation of their own data, which contributed, I think, really strongly to the overall CBPR approach, and allowed us to generate findings and interpretation of our findings and applications for our findings that were really grounded in community perspectives. So CBP-AR, and in SoLaHmo, we add the A in. Most people are familiar with the term CBPR, community-based participatory research. We add the A in for action because we feel very strongly that our research should leave some kind of change in the community, some kind of program or intervention or benefit to the community that communities want. And so our working kind of term for today will be CBP-AR, although you might see CBPR pop up. So this is our working definition for today. I'm going to give you a minute to read it and just let you know beforehand that this is Barbara Israel's definition. She's a faculty member in the School of Public Health at University of Michigan at Ann Arbor. She's considered one of the grandmothers of CBPR in the West. So I'll give you a minute to read this definition. And just to note that this approach comes out of Brazilian educator Paulo Freire's popular education tradition, which some of you might be familiar with, and it can be adapted to a variety of disciplines, including evaluation science, education, service provision, et cetera. We're now even seeing it in environmental sciences, which is really exciting. But generally, CBP-AR allows room for participatory decision-making on all aspects of a study, including at the very beginning, what needs to be researched. And this creates a new paradigm, which wherein the research field is expanded with the community as drivers, who are then able to contribute to identifying key and urgent unmet needs. Taking this approach involves the adoption of a community academic partnership approach in which research is conducted among equals with complementary knowledge and expertise. And each person's expertise is really valued around the research table and contributes to the overall design and success of the study. CBPR partnership building is the process of establishing and sustaining a mutually respectful relationship based on the sharing of responsibilities, costs, and benefits, and with outcomes that are satisfactory to all partners. And just a note that CBPR isn't for everybody, but it can be used in bench science as well as community engaged approaches. Okay, and then I think there's a slide just prior to this. So this is another definition that we really like in SoLaHmo. It's by Randy Stecker, a sociologist at University of Wisconsin-Madison. I think he's retired now. But he really points out that CBPR is not just a research project. Really, it's a tool for creating social change. And it has three main goals: learning relevant knowledge and skills, which is in line with conventional research of knowledge generation, developing relationships of solidarity, and these ideally are lasting relationships where a variety of topics can be studied and problems can be solved, and strengths can be identified and perpetuated, and then engaging in action that wins victories and builds self-sufficiency. So the research in itself is not a goal, but it's a method to achieve these broader goals of social change and health equity change. So community engaged research happens along a spectrum from researcher-driven to participatory or community participatory. On the far left of this spectrum, researchers or academic partners or academicians really select the topics, the research questions, and the methods, wherein a fully participatory approach community and academic partners work together to decide on topics, research questions, and the methods that are going to work best within a particular community. In a researcher-driven approach, power and decision-making really reside in the researcher's hands, whereas in a participatory approach, power and decision-making are shared. And there are skills there that need to be built to practice sharing of power and shared decision-making. And consensus building is key in these partnerships. In a researcher-driven approach or conventional approach, the experts are considered the academicians. And in a fully participatory approach, there are a variety of types of expertise that are valued across the full life of the study. And all team members are considered both experts and co-learners. In conventional research, a major goal is knowledge production. And in a participatory approach, knowledge production is also important, but primary goals really focus on improved health, empowerment, and capacity building. So we talk about CBPR not just as research or a research approach, but really as a social justice enterprise. So in conventional research, where you have a lead academic researcher, the community to be engaged in the study can feel disempowered, like research is being done on them. And we have numerous examples of that, communities being overstudied. So a CBPAR approach switches up the power relationship to both do better research, for example, by creating study designs that work well within a particular community, and doing analysis and interpretation of findings that more accurately reflect the community's cultural context. And thus can lead to social change, to change social conditions and social relationships. And CBPR may help address barriers to using research findings. How often do we read about research that sits on the shelf, where real change doesn't come about as a result of the research? In CBPR, the translational process is really important and is a major goal of these studies. So we really, in CBPR, really want to get the products of research into the hands of the people who will use it, providers, policymakers, and community members themselves. Okay, we can go on to the next slide. So this is a set of CBPR principles, and I'm just going to let you read them, take a minute and read through them. There are different ways of kind of describing CBPAR principles. These are the ones that we use in SoLaHmo and that we created together with the Program in Health Disparities Research in the Community and Family Medicine Department in the medical school at the University of Minnesota. So I'm just going to give you a minute to read these 8. And if we were in a more kind of intimate Zoom setting, I might open up for discussion on this slide and ask you, what thoughts do you have on any of these principles that you'd like to share? Ones that you find particularly interesting or useful, or even challenging related to your work or your research or your experiences. The kinds of things that people typically focus on when we open this up for discussion are, in number 1, this idea of ethical protections for communities, not just for research participants. Communities can be stigmatized by research, and in CBPR, we really place a strong focus on making sure that we are not doing community harm in any way. Another that people tend to focus on is creating a balance between knowledge and action for the benefit of all partners and benefit of community. And then this idea of equity, really focusing on the collaborative process and the equitable involvement of all partners in all phases of the research. So this is like starting way at the very beginning at the grant writing phase, all the way through to sharing our findings, both in academic and community circles, and then thinking about what needs to happen next. All right, and then the next slide really points out kind of three foundational components of CBPR partnerships. And these three components, trust, shared decision-making, and shared power, are also its challenges. Where these are not established well early on, problems can happen in these kinds of partnerships. And so it's really important for academic and community partners with their combined interests and unique areas of expertise to come together to form these partnerships in ways that are grounded in these three foundational components. And when done skillfully, it's possible to build trust, engage in shared decision-making, and this can lead to increased understandings about the societal power imbalances that have led to the topic being studied, and overcome some of those power imbalances within the research partnership itself. So CBPR as an approach or a movement is a response to the long and often negative history between universities and communities surrounding research. And this history includes, a long history of human subjects abuses that have contributed to the resulting mistrust that communities have for research. So we're really trying to build trust in the research enterprise in and of itself. And I will pass the platform to Sey to share some detailed information about our particular study.
Thanks, Shannon. Thanks, everyone. So this image and CBPR was what drew me to this work, and this image shows why I do this work. So as the Hmong community researcher, I have one hand reaching out to the research team, and then the other hand reaching out to the Hmong community, because we really can't do this work without the community. The hands also allude to the simple but essential fact that trust is an action. It's a continuous process operating within power dynamics. So I'll be sharing what SoLaHmo, some Somali, Hmong Latin American parents of seriously ill children told us about their healthcare experience and trust. So we held focus groups with 26 parents, 8 Somali, 10 Hmong, and 8 Latin American. Less than half the parents spoke fair or limited English, while over half received WIC. WIC is a nutrition and breastfeeding program for low-income families. All of the Somali and Hmong parents had health insurance, while only 13% of the Latin American parents were insured. So these demographics is just a simple, rough snapshot that alludes to larger social determinants of health for these parents that participate in our study. The parents desired a two-way trusting relationship with medical staff, a trust that is built on informed understanding, compassionate interactions, and respect for parental advocacy. So all these key components are interrelated. You can't have one part without the other because they all rely upon each other to foster trust. So again, for context, since these parents had children with serious illnesses, a majority of them either had a history of or were actively in and out of the emergency room, hospital, or neonatal intensive care unit, being seen by multiple specialties and subspecialties. So on informed understanding, the parents talked about wanting regular communications from each medical team member that was consistent. When staff took the time to explain things and answer their questions, parents felt that they could trust the medical team more. However, when parents weren't informed about medical team structures and processes, the who's who and what's what of the hospital, there was frustration about the quality of the medical care. So this is what this parent here in the quote touched on. When the team made it evident that there was consistent communication within the team by reinforcing the same information to parents, then the parents felt that they could trust more because that everyone was on the same page and they were all getting consistent information. Given the medical complexity of these children, these parents wanted staff to walk them through the medical picture in clear, simple words. So when parents felt that staff couldn't explain things in a concise way, where they could understand and struggled through it with them to make sure that they were actually understanding what was going on with their children. It caused parents like the one here to wonder whether information was being withheld. And then once that thought came, then it eroded their trust. So on compassionate interactions, the parents talked about how there's no separation between quality medical care and compassion. So in order for medical care to be considered good medical care, the team had to show that they cared. If staff showed caring, then the parents were more likely to believe that their children were actually getting quality medical care, making them feel like they could actually entrust their children in the care. Like this parent here talked about the NICU nurse. And given the severity of their children's illnesses, these parents leaned on their faith and cultural traditions for guidance. When the staff intentionally included this, like the nurse here who played the Quran for this baby in the neonatal ICU, it made parents feel more at ease in their healthcare experience, which then made them feel like they could trust staff more. Parental advocacy. So the parents talked about how they had to learn how to be advocates for their children. Advocacy was expressed as being on a spectrum. So like this parent here who talked about having to undergo a harsh reality in order to learn how to be an advocate. Parents wanted to be listened to and actively included in decision making. And so that's what this parent here is also expressing, wanting to actually be part of the process. But the parents also talked about the need to moderate their advocacy at times along the spectrum for fear that being too much of an advocate would directly negatively affect the care that their children were getting. So like this parent here talking about going to the social worker as opposed to the nurse because they felt like they were going to mistreat their child. Parents trusted the medical team with their children's lives and their lives, and they wanted the medical team to trust their role as parents. So again, reinforcing that trust takes two. For ethnically diverse communities, racism and biases, as well as language barriers, can very quickly and deeply erode trust in healthcare. So that is why being aware and proactively addressing them can prevent mistrust, but also help to build or rebuild trust. So racism and race. Medicine was built on a history of racist experiments on Black people in America. So from Marion Sims in the early 1800s, who was the father of gynecology and did forced surgical experiments on Black women, to Tuskegee in the 1930s, where Black men with syphilis were deceived into thinking that they were getting treatment. The parents we interviewed talked about how this history was in the back of their minds. So like this mother who recounted a story of her baby coming back from the operating room with a central line that was placed in a different location than what she felt was explained to her. And so it felt like she was consenting to something. It was different from what she had consented to. So I imagine the clinician, their goal is to place the central line access wherever they could to save this baby's life. However, and for them, it wasn't a matter of race. It was a matter of doing their job. But because of the history of racism and research, things like changes in plans caused parents to worry that they were being experimented on because of racism. And then subpar outcomes also made parents think that medical errors were happening due to racism. So these are the fears that these parents were talking about when they come into the interactions with the medical providers. But it's not just about the history. So false beliefs about physical differences between different races pervade to today. So in the 1700s, this British doctor claimed that Black people could bear surgical operations easier, that they had a much higher pain threshold simply by the nature of their skin. And then, in this paper here by Hoffman, published in 2016, they sampled medical students and residents about this false belief that Black people had more pain tolerance. They saw that those who endorsed these beliefs rated the Black patient's pain as lower, which is plotted on the top graph, and also made less accurate treatment recommendations for the Black patients, plotted on the bottom graph. So it's still pervasive to today, these false beliefs. And relating back to the parents in our project, the parents talked about, again, being worried that they were perceived, that what they perceived as unfair treatment or poor quality of care was, again, due to their race. And race has no biological basis. It doesn't represent human genetic variation. Because race is a social concept, it seeps into interpersonal, institutional, and structural interactions. There's no magic bullet solution for solving racism in medicine. for dealing with the hideous history of all of it and how it rears its ugly head today. But on the levels that we can make an impact, it relates again back to trust. Trust being an action, a continuous process operating within power dynamics. It's about showing up in good faith over and over again and recognizing that we're all in this together to build solidarity and to build trust. So I'll turn it over to Jen to talk about the language barriers piece.
Thank you, Sey. And I want to move through this quickly because we have some recommendations from parents that I think will be very valuable for our audience. But I just want to highlight, as Sey presented early on, that a significant number of the parents in our studies did not feel as if they had good English language skills. And so we found a significant number of responses had to do with language barriers impairing communication and trust. And just to go through this very quickly, healthcare institutions are required to provide meaningful access to professional interpreters, but data demonstrate probably about 30 to 40% of health systems across the country, particularly in more rural communities, do not have access to language interpreters. And as we think about the growing number of non-English speakers in this country, this map represents most common languages besides English and Spanish in the United States. And one can see that the need for a large number of language interpreters is a moral necessity within the healthcare system. I won't speak about language barriers more because I want to get through, but we're happy to talk about some proposed work we're going to be doing with informal or ad hoc interpreters for our next project. So we talked a lot about the findings from our study and what we know from the data. And the question is, what can we do? What can we do as boots on the ground, individual care providers to help community members who are vulnerable and feel powerless within a healthcare system to feel more trusting of the medical care we provide their children with serious illness. And based on the 3 themes we found in our work, some recommendations from parents really are not earth-shattering, but I think clearly we are not communicating well to parents. I think given the constraints of an ICU environment or a busy hospital system, particularly since COVID, providers' ability to spend more time and manage more of the non-technically medical elements of healthcare has really diminished. And I think one thing I just want to highlight from here is the need to acknowledge and not dismiss errors or mistakes that parents believe to have occurred. Providers oftentimes feel insulted that people think that there was a mistake or an error, but managing it by just communicating more medical information as opposed to really evaluating what led to that concern or mistrust would really be a mistake on the part of the providers. And another interesting thing that we found was how significant emotional words and topics were to shutting down communication and parents' inability to trust. I will highlight that many of our parents who were diagnosed in utero with children with serious illness felt that their trust in the medical team was damaged at the point at which they were offered termination of pregnancy, and that they really didn't ever gain that trust back. So understanding that certain things that are presented as medical options or in the medical context may carry a significant amount of emotional weight. Shannon.
So some recommendations around building trust through compassionate interactions really had to do with the ways in which providers and care teams show that they care, both verbally and non-verbally. And parents talked about, some examples that came up were, just being offered a cup of tea. Very, very simple things allowed people to feel cared about, grounded, and more trusting. Taking some time at the very beginning to getting to know the patient and the family. This is one of those situations where a little bit goes a long way, and skipping that step can really undermine the process of building trust. And then recognizing that there's a lot of diversity within communities, and diversity of thought, diversity of belief, diversity of what speaks to people. And so while learning about a particular cultural group is an important step, to keep your thinking flexible, so that you can really connect with patients and their families in ways that work for them. All of this can help contribute to decreasing the perception of power imbalance, or the experience of how that plays out for families and patients, especially when they're feeling vulnerable in these situations. And I will pass it on to Sey.
So to build trust through supporting parental advocacy, it's about respecting the role of parents and recognizing that they're speaking up from a place of love and concern for their children, which includes making sure that they and whoever else they want to include are actively part of decision-making, how they want to be part of it. It's about supporting parents as well and increasing their access to support services and cares. So this is a list of recommendations from the study and the parents. And then all in all, what can we do to build trust with parents and their families so we can trust more and trust often? So it's on us who represent institutions to show that trust can be made, that it's not in short supply, because we can trust so they can trust us. And I'll hand it over to Shannon, and then we'll do questions.
So just a couple of opportunities for anyone in the audience who's interested in learning more about CBPR. SoLaHmo is involved with the University of Minnesota Clinical and Translational Science Institute and their Seed to Dream study. We offer communities of practice as ways for community and academic partners to build skills around CBPR. So if you're interested in learning more about that, you can reach out to Seed to Dream at this email address. And then we also worked with the Clinical and Translational Science Institute to create a virtual module called Equity Grounded Community Engaged Research. And it's on the CTSI website at the University of Minnesota. And let's see, am I able to put that link in the chat?
I will.
And we can send them out in
Okay.
the post-event information. So thank you. That was wonderful. You've given us a lot to think about. A number of questions. Let me start by picking up where you left off, which is talking about CBPAR. One of the questioners would like to know if you can suggest some ideas for encouraging that approach with students. How do we encourage students to participate in the development of questions, outreach, surveys, refinement of the educational experience using CBPAR as an approach or a tool?
I can take that one. I think that's a really important question because for a variety of reasons, but I think really educating young people about this approach, young people who intend to go into research potentially, or fields that rely heavily on research. It's great to start introducing these ideas early. And so depending on the age group that you're talking about, there are, for young people, junior high and high school students, there is a great, it's called Youth Participatory Action Research, YPAR, training program that's online out of Berkeley. It's called the YPAR Club. And in SoLaHmo, we adapted that to a school-based setting in the St. Paul Public Schools and worked with junior high and high school students to do their own research on school climate change as a public health strategy for school connectedness. And I think in terms of higher education, there are a variety of ways for people to get involved. I think because students are a transient population, there can be opportunities created for students on projects. I think one important piece is bringing them on to a project in a way that orients them to the CBPR approach. and really engages them in collaborative processes right from the beginning. In SoLaHmo, we often have members who are students who get involved in projects, studies because they're interested in learning to do research. They might see it as a stepping stone toward their own academic and career development. And many of them tend to stay on beyond their academic pursuits and continue to do research with us. So I think possibly finding ways to tap into their interests, I think especially for students who are from communities that are disproportionately affected by health disparities, it can be a really wonderful way to kind of light a fire and engage them in contributing to the health of their own communities. But yeah, there are tools online, I think, and creating opportunities for them to feel supported in their academic requirements and goals. So creating opportunities for them to co-author papers, work in collaborative ways with a CVPR team to do that, and present at conferences, develop posters, and even take the lead on certain pieces in a collaborative way.
So often what we do in grand rounds when there are questions for which speaker teams have great resources, as I know you do at SoLaHmo, is that we'll post resources to the event page on the center website, and we can disseminate them to people in the post-event emails. So we'll collect some of the resources that Shannon has just mentioned and make sure that they get disseminated to folks. There are definitely some additional questions in the Q&A about resources for education or involvement, inclusion in CVPR. In the interests of time, though, I'd like to get to at least one or two more questions. So one question is really about the role of interprofessional collaboration in building trust. So not individual providers, but provider teams and interprofessional teams. And I wonder if someone could comment on that.
I'd be happy to. I think that this is such a fundamental component of palliative care. Palliative care is an interprofessional, interdisciplinary practice, which that concept of including health psychology, spiritual support, art therapy, integrative therapy, all of those things that really matter to parents and patients, hasn't quite made its way to the other subspecialties within medicine, which, especially for children with serious illness, are probably oftentimes in these really sterile, impersonal environments like an ICU or a hospital. And I think that one of our recommendations was to refer and improve access to palliative care. And I think including palliative care teams as interdisciplinary teams for parents of children with serious illness is particularly critical. And for those teams that are not functionally interdisciplinary, like palliative care, such as an ICU team, really raising awareness about the role of spiritual health, and understanding that for many of these parents, attending to their spirituality is actually more important than attending to their needs for medical information. And I think that there needs to be a higher level of consciousness across the health system as a whole, but among providers, as to the critical role of chaplaincy in well-being for patients and families, particularly from communities that are already fairly mistrusting of the way the health system has valued their cultural experiences.
Thank you. So we're a little bit over time, but I would like to just ask one more question so that we can, it's a very important question that one of our participants has asked, which is, you've talked some about, provided some great insight about how to establish and maintain trust. But this questioner wants to know, how do we repair trust once it's been broken? Do you have just a few quick suggestions about that? I know we could talk about that all day, but
Steve, would you like to answer that, or?
Jen, you can go ahead if you.
Okay.
Yeah.
Well, it's a great question. And I know that oftentimes we arrive in a patient interaction as a provider with someone who's had an entire life experience with the medical community that may have not been good. And so they bring that history into their exchange with us. And I think what's really important is to just name the mistrust. I think we're so hesitant to open up anything that may create more time necessity in the part of a visit, the need for some emotional exchange, or in fact, owning that a patient was harmed or not treated well, and that was the cause of their mistrust. So there are risks with acknowledging that there is mistrust, because you may set yourself up to be misinterpreted, or the way that one handles a conversation about mistrust, I think, needs to be done delicately. But I think repairing trust requires two things: acknowledging the history of mistrust and the causes of it, and then moving forward to ensure that the things that caused the mistrust in the past are not present in this interaction. So for the family who thought that their child was experimented on because the central line was in the neck instead of the femoral, for that family moving forward now, further communication needs to acknowledge that we may change this based on what we find in the operating room, and we will come talk to you about it before we do something differently. This is not to say that there isn't sympathy for providers. Here, providers are overworked, underappreciated, and being required to manage a lot of patient needs that are not within the skill set of a physician or nurse. And so we recognize that what we're asking of providers or individuals really does create some difficulty. It's hard to acknowledge people's experience with racism or mistrust. But I think we move our community forward by recognizing that this is what patients bring to the table, and then really moderating and responding to that understanding.
thank you. I very much appreciate you all taking the time to talk to us about this really important research. And thanks to everyone for hanging in with us for a few extra minutes. This is our last Ethics Grand Rounds webinar of this calendar year. But you can see on the screen there the plan for early next spring. There will be more information coming about these and other events. We have a great lineup of additional webinars, both in the Ethics Grand Round series and in the Unpacking Bedside Bioethics series for you in spring semester. So look for information about that in your email and your social media feeds, and we will see you hopefully all again next semester. Thank you very much to our speakers for today.